My name is Shane Doyle. I'm the VP of Sales and Marketing here for Implanet America, based in Boston. We're very excited today to have Dr. Brice Ilharreborde from Paris, France, with us. Brice has, if not one of the most prolific band users worldwide, and practices at the Robert Debré Hospital in Paris, specializing in pediatric orthopedics and deformity surgery. So the goal of the presentation here is Dr. Ilharreborde, Professor Ilharreborde, has had many years of experience with bands from many different providers, of course, including Implanet. And the idea here is for Brice to give us an evolution and how his techniques and philosophy has evolved over the years with bands. So without further ado, Professor Ilharreborde.
So I'm very excited and very happy to be here and share my experience. It was actually pretty interesting for me to prepare that talk because I really had to look back at all these cases we've done since almost 2005. So for those of you who don't know me, I'm in Paris right now. I'm the head of department of the pediatric orthopedic department in the University of Paris, and my hospital is called Robert Debré. And my previous boss, the head of department, was Professor Mazda, who's the one who basically developed the sublaminar bands. And I have to say that when I first met him, I was maybe third-year resident, and we got along very well. And I was in the sublaminar bands adventure really early on, and so I've been really like witnessing the evolution of the band. I was there when we did the first cases. And because I wanted to work and keep on working with him, I also pursued my career in biomechanics. And I did a 2 years fellowship at the Mayo Clinic in the biomechanics lab, on which I worked a lot as well on the band, on the biomechanical properties of the band. So I really know the product from scratch, I would say, from our early on experience to the biomechanics. And I've also witnessed, I think, most of the mistakes that can be made with the bands, and I'll try to share that with you. So I think it's important for you, from Shane told me, most of you know the products, right? But I think the problem that a lot of you, when they go and see this, new surgeons or new users are facing, is that first of all, a lot of them are not aware of the literature, because for years it was kind of a topic that was not discussed widely in congresses. People were mostly talking about their screws, what kind of screw, what kind of derotation maneuver they were doing and everything. And more you started to see appearing in the cases that people were showing some bands. So people know the products, but a lot of them are not aware of the literature, and a lot of them don't really know what it's made for. So I think I'm going to try to summarize our experience and give you some clear take-home messages for anyone who would be already a user, to reinforce his knowledge about it, or to actually get some new users. So first of all, I think that's important to see what are the bands necessary for. What can you do with bands? So of course, because that's our main practice in Robert Debré and in the French department at first, was mainly scoliosis, so deformity. So it can be all kind of deformity. A lot of people think that it's only for idiopathic cases, but actually I think there's a great advantage in neuromuscular, and we'll talk about it later. And it's actually easier to discuss with surgeons who have been doing a lot of neuromuscular scoliosis, because people have been using a lot of wires or any kind of tape, and they can just change that and use sublaminar bands instead. So we've also tried to use it in fractures, and you have an example in the middle. That's the picture here in the middle. That's a publication we made more than 10 years ago on a series of fracture. And basically the advantage that we showed on these constructs was that you could reduce the length of the constructs, because traditionally, when you have a fractured level, people tend to instrument 2 levels above and 2 levels below in order to get 4 points of fixation, 2 above, 2 below. But basically, if you combine at the same level a pedicle screw and a band, then you get your 2 points of fixation, but at a single level. So basically what we showed was that the construct was solid. It was long lasting because there was no loss of correction, And in our philosophy, it helped reducing the length of instrumentation. So that was published in the Journal of Pediatric Orthopedics, which is the American journal. And a lot of people still use it for that indication in France. We've used it for tumors, and that's interesting when you deal with surgeons in Italy or neurosurgeons, because a lot of neurosurgeons deal with tumors, but some of them, it's changing a little bit, but until a couple of years ago, a lot of them were not very experienced with the instrumentation, and I think sublaminar bands can be really helpful with them. We use that for spondylolisthesis, so that's we're starting to move towards degen. We've used it widely now the new development of bands and the auto-stable bands, the jazz lock. There are a lot of new indications in the cervical spine. And more interestingly, for surgeons who are dealing with deformity and older patients, is revisions. We've showed that for revisions, especially in case of a pull-out of a hook, of a screw, when the anatomy is damaged, it's really helpful to have bands in your toolbox, because then you can add it as an add-on or just to replace the implants. And we know that most of the adult surgeons who are doing a lot of deformity or degen, now they are up to 30 or 50% of revisions in their cases. And I think with all the new type of implants related to bands, you have a lot of things. And I think that's a really nice way to push new and get new users is really the revision surgery. So I'm going to give you the most significant message we got from our experience and our publication. I think the first point, which is key, is that sublaminar bands are safe. That's very important, because I have to say that when you first meet and when we have some visitors who are mainly old screw users, most of the times they're not against the concept, but they've never opened the canal. They're not used to that. So for them, using a sublaminar band is adding a complexity of the case. So I think there is a learning curve, of sure. It's pretty short, the learning curve, because when we have 1 or 2 year fellows, usually in our department, after a couple months, so I would say after 10 to 15 cases, they're they place the bands very easily and they feel really confident. So there is a learning curve. The idea is not to say that it's easy to make, but it's really safe. And I mean, Shane was mentioning that I put maybe more than 6,000, but I'm sure it's actually much more, because we do almost 200 cases per year since more than 10 years. So we've done a lot of cases. And that's the real pure truth. We never had any transient or permanent neurological deficit related to the bands since the beginning of our experience, never. And all our cases, and I think that's really mandatory, especially for new users, require neuromonitoring. It's very important to have a neuromonitoring. And sometimes when you have an experienced neurologist helping you in the OR, they can see sometimes they see a small signal on the neuromonitoring when you pass the bands, but it's not significant. It's less than 30%, and it always go back to normal after a couple seconds. So if you have a small alert, that doesn't mean that something's going to happen clinically, but it's possible. And that's actually something we've never published, but that could be maybe helpful to convince some people. But first message, it is safe, but you need a neurologist or a real neuromonitoring during the surgery. And basically, if you have a small change in your signal, as long as there is no dysautonomic trouble, such as hypertension and bradycardia, you can be really confident nothing's going to happen. It is very safe, once again, passing them. And I think that something that can be helpful when you want to pass the band at first is really to do a wide opening between your lamina. So basically, at first, we were not resecting the spinous processes, but now we do resect them systematically. And I tend to use more and more a resection of the distal lamina. So basically, you make your opening a little bit wider. Then you have access to the yellow ligament, and that needs to be opened, but not widely, just 5 or 6 millimeters, which is basically the width of a band, is sufficient. Because if the surgeon wants to open it too widely on both hands, then sometimes you have small vessels, and then you get an intracannular bleeding that can be a source of stress for the surgeon. One thing which is interesting is that the main advantage for me in terms of correction of the band is for the patient who have a flat back. They have hypokyphosis. And in those cases, actually, a lot of lamina frequently overlap in the patient. So it's pretty important if you want to have an easy access to the intracanal space to resect the spinous process and sometimes the distal lamina, but this is not mandatory. One thing which is important, because sometimes we get some feedbacks from new users, you see, it's pretty important if you look at the image on the bottom left, when you have a scoliosis, usually the spinal cord, which is in gray in the middle, is shifted toward the concavity. So if you want to be safe and reduce the risk of complication or any neurological alerts, tell your surgeons to place the bands from the convex side. So usually most of the scoliosis at the thoracic levels are right. So tell the surgeons to place it on the right side, which is here on the image on the left side, where you see the red arrow. Ask them to place that on the convexity, and then once the band is placed, they can place it wherever they want on the concavity. And it's important because the action of the band is going to be mainly on the concave side, so here, on the right side of the image. But the insertion should be on the opposite side. So the trick is to place it on the convex side, and once the metal part is passed and the band is passed, you can just translate it and move it toward the concavity. And that's important because one of the German surgeons who started his practice, he made 3 cases, and he told me that in the 3 cases, he had huge alerts, but he was inserting them from the concavity, and I think that's a mistake. Another publication, because of course it's not only our experience, this is a big paper that was published by the team of Marseille, and they also had a great experience because the philosophy took over pretty quick in France, and the teams from Marseille and Toulouse, who are big users, also started to use it. And they emphasized, first of all, the fact that they have a very low neurodeficit. They didn't have 0, they had 0.8, but that's not only due to the band itself, it can be due to the surgery itself. They still had a couple of alerts, so you have to set up and discuss with the neurologist what is a real alert in terms of level lowering significance. And they emphasize something which is actually interesting that I do in my practice, but I think it's important to note, is that if you look at the drawing that they put in their publication, the left side is the good one. The right side is a little bit more dangerous because you see, if you buckle too deep, then when you try to exit the tip of your band, the extremity of the curve can then push on the spinal cord. So it's pretty important to measure the length of your lamina, and it's usually basically the width of a thumb. And then depending on the level, if you're dealing at thoracic level, you can make a great circular curve. If you're dealing at the thoracolumbar junction, which is a little bit more dangerous in my mind, then make it a little bit flatter and you'll reduce your stress. And the key in your practice is really to overbend the tip, because then the tip, with the tip of your band, you will feel the posterior part of the lamina, or actually this is the anterior, but this is the deeper part. And then once you finish touching your lamina, bam, the band will exit. Another point which is of great importance is that it's great to put implants, but you want to make sure you can remove them. And that was a problem actually with people who were using Lucky wires, is that the insertion was safe, but removing them was very dangerous. So this is also very interesting. We did some preclinical study when I was actually during my residency. We did that in Paris in a lab, in the animal lab, and you see that we implanted a couple of bands in rabbits. And after,
dinero?
I have some Spanish. And after a couple months, we removed the bands, and we had actually, because that was a surprise, that was not in the charge of the preclinical development, but there was no. This is the band in microscopic view. This is the dura here in purple, and for some reason there is no fibrosis between the band and the dura, which means that at any time, and I have to say that sometimes I have removed some bands more than 10 years after, it just slides very easily. So it's always easy to remove, and you never have a risk of dural breach when you remove them. So that's important. I think the second thing that we have learned is that in terms of reduction of a deformity, it has a great potential. So we've done a lot of 2D and 3D analysis, And basically, the mean correction rates that we obtain were always, depending on series, between 60 and 80%, which is exactly consistent with what you find in the literature with surgeons who are using old screw. So old screw, both sides, full density. No one has more than 75, 80%. So we are, and sometimes with couple of bends, and I think that's something interesting, is that you see that usually we adapt the number of bends depending on the degree of the curve and its stiffness. So if you're dealing like here with a stiff curve, you need a lot of bends. If you're dealing with a very flexible curve, with only 4 or 5 bends, you can get the exact same correction as you would have gotten with 20 screws, 10 on bilateral. And I think the key part is that in terms of frontal correction, you are equivalent to the best full screw in constructs. But in terms of sagittal alignment, you get a much more powerful reduction maneuver. And you can see that on the drawing is that basically everybody knows that the hardest part is to pull the spine posteriorly through the concavity, which is usually the left side of your thoracic curve. So if you're using a regular screw like here, you basically have to push your rod in the screw, and then you always obtain a flat rod. So some surgeons use a very long reduction screw, but then at some point, when you're using the reduction tools, at first you see that the spine is moving back, and at some point, when you reach the flexibility of the spine, then the screw pulls out. And the thing which is different and interesting with the bend is that if you do the same maneuver through the bend, then the spine will move back, and at some point, maybe it will stop, but then you will never see a fracture of your lamina because the strength of the lamina and the contact of the lamina and the bend is much, much stronger than the insertion of a screw through a tiny pedicle. And same thing, which is also interesting, is that a lot of people feel that because we're doing that and because we don't have screws at that level, we cannot derotate, but that's actually untrue because we've done a couple of 3D analysis post-operatively, and basically we noticed and observed and reported actually that we got a 50% reduction in the axial plane, which is same thing, not less than what people get with screws. So I think it's very also helpful to reduce sometime implant density and sometimes costs. And if you look at those two cases, the one on the top is taken from a publication, and it was actually a publication made and supported by the industry, not ours, as you can imagine. And the bottom one is one of our cases. If I selected this one because if you look at the pre-op frontal, they're almost similar, okay? If you look at the post-op frontal, they're both really good. If you look at the lateral view, the one with only screw is completely flat, it's straight. So of course you can see that people wanted to give a big lordosis, but you can see the difference of the shapes between the two rods, and basically what happened was that the concave rod flattened. And if you look at the sagittal contour that you get with your sublaminar bands, it's much better because the concept is really to bring the spine to the rod. And if you're using very stiff rods, then you get much less flattening of your concave rod. And you see in terms of complexity, I took the data that was reported in this publication. The surgery lasted 5 hours, blood loss almost 1 liter. And this is one of our case, less than 4 hours and almost half the bleeding. So in terms of sagittal correction, I think this is really key because this is really published, scientifically published with sufficient literature, and that's a key point for spine surgeons. I think if you go and see new spine surgeon and deformity surgeon, you can tell them that can be an alternative to your reduction screws on the concave side. So for that reason, the stiffer your rods, the better your correction. If you're using a 5.5 titanium rod, then your rod will flatten pretty easily because you will reach easily and early the great flexibility of the spine. That's why we decided at some point to strengthen our construct, and we developed the simultaneous both rod reduction, because then we reduced dramatically the flattening of our rods. I think the key is to use and get a good distribution of the force. So you need at least between 3 and 5 bends on the concavity. and act simultaneously on all the bands during your correction. Another point which is important is that the bands are much less dangerous than the concave thoracic screws, because everybody know, and all the anatomical studies that have been done have shown that the upper thoracic pedicles most of the times are very small. And there is, as you can see on this publication and on these pictures published by the Twin Cities Hospital, they made some cadaveric post-mortem analysis. You can see that the pedicle on the concavity, which is the thinnest one, is very dystrophic. So you can easily understand that on these pedicles, you cannot insert properly a pedicle screw. And that's why you have a high rate of misposition. And if the screw is mispositioned, it can be lateral, which is not a great danger, but then your screw doesn't have a great biomechanical strength. So if you want to apply traction on these ones, the screw will pull out. But you can also be too long, and this is close to the aorta, or too medial. And all the best series based on post-op CT scans have shown that 10 to 15% of your screws are not perfectly placed. And this is dangerous in surgery. And another point is that if you're dealing and looking at the literature of all screw constructs, once again, it's been shown that every time you get better frontal correction, every 10%, you lose 1% of kyphosis. And if you look carefully at all this X-ray, the frontal view is not so bad, but always the flattening of the concave rod is always obvious, and you have a final different sagittal contour between your rods. And that just traduces what happened during the surgery. Another point, because a lot of people have focused on the derotation at first, it's been shown that in scoliosis, because of the deformity, the anterior part of your vertebral body becomes taller than the posterior part. So if you get a perfect derotation and try to put all your vertebra completely derotated with your screw, you will automatically end up, like you see on the drawing of the whole spine, with the flat back. Because you derotate every vertebra, the longer part becomes anterior, and then automatically you end up with a flat thoracic spine. So maybe derotation is not the most important part of our correction, but it's the sagittal alignment, which is. And we've done some 3D analysis based on EOS imaging and also on CT scan. And this is just a short series, but that's the one that was published, about 115 cases. And you can see that, and this is actually, I think, a good case to show. This case in the middle was completely flat before surgery. And you can see that post-op, he had a really nice and harmonious sagittal contour. And the case on the right is even worse because he was a hypokyphosis, completely lordotic until the thoracic spine, and we were able to restore the sagittal contour very properly. And in our series, most of the times, no matter how many hypokyphotic patients we have at first, they almost all go back to normal sagittal alignment post-op. This is another example, completely lordotic preoperatively. Two cases that I found in marketing publications from other competitors. And if you look carefully at the sagittal contour, the sagittal alignment is really awful, actually. But ours is always much better. So the idea is, once again, to bring the spine to the rod. So it's very important to try to say and tell surgeon that the stiffer the rod, the better it will be for the sagittal alignment. So my recommendation is always to use Comal Chrome. If you can, it's even better to use a 6 millimeter, at least on the concavity. And if you want to increase again the strength of your construct, you can use a double rod construct. Another point which is interesting is that until 2012, we used to do for stiff curves a previous anterior release prior to our posterior fusion. But since we've been using aggressively the bands, we've stopped doing anterior release. And we've done a series comparing the correction of the patient who were anterior released and the ones who were not. And the final correction was exactly equivalent. So now we don't do that anymore. So the strength of correction from the posterior spine is really huge. Then if you want to increase your derotation, because some surgeons still want to put an emphasis on the axial plane, and this is a cosmetic demand as well for the patient, because if you get a better derotation, they have less rib hump remaining after surgery. you have two possibilities. I think the first possibility is to use a double rod frame technique that we've published in 2019. And I have to say that we got a lot of great feedback from the surgeons in terms of even like I was talking with Michael Vitale in New York, and he thought it was a great paper. And basically what we said was that by using two rods simultaneously, we were able to get a center of rotation on the convex side at the tulip rod junction that we left opened. And then when we applied the traction force on the sublaminar bands, the whole spine rotated. But the good point is that we didn't have to push on the convex side. And I think the other technique for those that you will not convince with full bands constructs is to add convex pedicle screw. So the idea, and that was initially introduced by some of our German colleagues, was to add or maybe to keep on using some convex pedicle screw, but then using some sublaminar bands on the concave side again. And then, once again, even with one rod, if you connect your rod on the convex side with the tulip, but leave it open, because of course, if you tight the setup screw, nothing will work, then you can place the tension on the band and you'll get the same derotation. And I have to say that that's the kind of construct that I'm doing right now. So the image on the right is one of my most recent construct, I would say. So I use pedicle screw bilaterally in the lumbar spine. I use convex uniplanar screws on the convex side, and I use between 3 and 6 concave sublaminar bands based on the pre-op CT scan at every level when I see that there is no screwable pedicles. And I just made a quick feedback and analysis of our type of constructs. So you could see that this is the kind of construct we were using more than 15 years ago, actually at the beginning of our experience. It was mainly bilateral sublaminar bands. Then we moved progressively to full bands because we were very enthusiastic and said, okay, maybe we don't even need anything else. So let's try all the bands. And progressively, we stopped doing this because at the top of our constructs, we were not completely happy with the stability of the bands. So we replaced them in 15 with hooks at the top. And then we moved to bilateral rod simultaneously. And then we moved to those convex, or I would say hybrid construct that you've been using. But you see that we use more and more implants. So the density of implants is still high, and I think that's necessary, especially on the concavity. And these are my most recent constructs, once again, and I think that can be interesting mostly for the American users, because we know that American surgeons, they love pedicle screw. So it will be very hard for you to just convince them and saying, okay, just stop your pedicle screw, go to bands. But you can progressively make them replace the concave reduction screws that they're using by sublaminar bands. And you will see that they'll be really happy, and it's much easier than to use the reduction screws and much smoother for the correction. So the correction is mainly made from the concave rod, but then you can add a little bit of derotation by using the opposite, the convex pedicle screw. And once again, the main indication to say is that many use all the bands when you have dystrophic pedicles. So that applies to idiopathic. And in a lot of non-idiopathic cases, when they have bone disease, and this is very frequent in pediatrics and neuromuscular, then you can tell the surgeon that the resistance to pull out of the bands will be better than a pedicle screw. So other messages we've learned, which are very important, is that there is no loss of correction over time. And that's pretty important because we wanted to make sure the constructs were stable. And now you see we have actually a lot of patients with more than 10 years follow-up, and none of them lost correction over time. Another point, which was a frequent question when we had visitors in our centers, was that a lot of people were worried that having some kind of braided band, if there was an infection, would be more difficult to heal because maybe the pathogen or the germ would remain in the band. So basically what I did is that I looked retrospectively at all our infected case. And actually, first of all, the incidence of infection was low, 0.2, which is in the lowest range of the literature. But then we were able to find and show and prove that even if you have an infection, you still have to do a revision like everybody has to do, but you can only do a single one. And what we did, which is called early revision, is that we only did a debridement. So we opened the wound, we cleaned the wound and the implants, and we closed the wound. Basically, we never changed the implants. So it's what it's called implant retained strategy, which means that even if you have an infected band, that will not affect the fact that you can heal easily from it. So I think in conclusion, the key message that you want to know is, and that's what I have in my mind, is I really need sublaminar bands in my OR. It's really something in the toolbox. I don't think you want to tell surgeon that it will replace everything, but that's really something. If you have hooks, pedicle screws, and sublaminar bands, you can do all the cases, everything you want to do. I think they really make my life easier. So once you have passed that short learning curve, it's very easy to use. It's very easy to bend your rod. I'm very confident placing them, and I can really help my residents and fellow placing them very confidently. And I use them more for correction than stabilization. I think that's important. I think once you do your correction, you lock the band, and the correction lasts forever. If you want to do some dynamic stabilization, that won't work. So if you do, you have to be careful if you want to use them at a very mobile segment, because the mobility that you get at the band and the claw junction can maybe sometimes soften and get loose a little bit over time. And I'm sure that more indication will be found now by new users. And I think there's a great potential in screw protection versus cementing the screw, for example. I think one of the components would be to compare a screw protected by a band versus a screw which is cemented. And that is very important to say if for people who are dealing with older patients. And the key point in adult population as well, both in degen and deformity, is the PGK prevention. And I think you can use either the regular bands or all the new type of bands that can connect either to a pedicle screw or to the rod. And for sure, there is clearly sufficient literature right now. And that's actually interesting because I just received last night an email from a surgeon from LA who has to do a presentation on the band. And he said, can you send me all your articles because we have sufficient literature to defend the band now. And I think that's something that you have to tell surgeons because they have to be aware of that. And if they want to get it accepted or reimbursed in their institution, it's important to show the papers. And we clearly have enough right now to support all these findings. So thank you for listening to me. And I guess we have about 20 minutes now. So if you have any question, maybe go through Shane or any question you faced when you try to introduce the bands for the surgeons, I will be really happy to answer.
Professor Ilharreborde, thank you very much. That was a very informative presentation, and I do have some questions for the group here. Clearly, you have many years of experience, but based on your experience and your interaction with other surgeons, what's your estimation of kind of the expected learning curve, or kind of how many cases or times will it take for a surgeon to be comfortable with passing the bands, and then of course with the philosophy as well?
I think it depends on who you're dealing with. If you're dealing with an experienced surgeons, an older generation surgeons, for example, who has been using Luki wires, then the learning curve is immediate. There is no learning curve, basically. So if you go to someone in Mexico or to Latin America or Mexico, and they've been using the sublaminar wires or the Luki wires for years, then you don't even need to explain them. They'll go straight away, and they'll go right away. But this is for them an improvement of Luki wire. If you're dealing with a surgeon who's been only trained with pedicle screw, and I guess all the newest generation in the US have only been trained with sublaminar, with a pedicle screw, I think the best way, I mean, the number of cases is pretty limited, it's very low, but I guess visiting one surgeon who's experienced with it really helps. just to feel that that moment when we pass the band during our surgery is not a stressful moment, you know? So it's not only the technique, but it's just feeling the fact that it's not the stressing part of the surgery for the surgeon. And then people get that it's easy. And once you get them, you give them one or two tricks, after 2 or 5 cases, they'll be confident and comfortable with it.
See, kind of to piggyback on that question. Uh, Sometimes we have surgeons in the U.S. that are also asking about passing around ribs or transverse processes for fixation. And do you have any thoughts or recommendations around that technique?
Yeah, I think that's well, I would say that that's pretty important. So if actually there are a couple of papers that have showed that you can also get a good reduction of deformity if you pass them around the TP, the transverse process, specifically at the thoracic spine, because at the thoracic spine you have a very strong junction between the TP and the ribs. So basically, when you pass it around the TP, you have a very strong connection. So it is strong. The idea as well for that, and for those who are using them, because some surgeons are only doing this, is first of all to avoid opening the canal, so they feel it's safer. And it's true that it's very safe to pass around the TP. And they also say that because they are more offset of the spine, they have better derotation because the lever of arm is greater. But in my feeling, I feel I have a little bit less of correction. So I think it can be a plan B. For example, we've done that once. The first time we did that with Dr. Mazda was an interesting case. I was a resident with him. We did the surgery on a complex case. It was not idiopathic. Nothing happened during surgery, and the patient did an hematoma in the first 6 hours of the surgery, but an hematoma not related to the bands, an hematoma because the patient had a blood condition. He had a hemophilia. So we had to go back to at the surgery the same night. So we reopened the patient right away. A couple hours later, we reopened, and we had to do a huge laminectomy all along the spine to get rid of that hematoma. Luckily, the patient recovered, but at that point, we were kind of stuck because we had no point of fixation. We had opened everything, and we said, okay, what are we going to do? Should we re-instrument everything with pedicle screw and do it again? And then we said, okay, why don't we use the TP? Because even after a laminectomy, you still have the TP. And we placed all the bands around the TP, and it actually worked well, and the patient is still completely solid and fused and never lost correction. So I think it can be a plan B. It can be introduced to the surgeon. I wouldn't say it's my option number one, but it can be used as an option number two, and also say that if surgeons want to use a band on a level that will be released or laminectomized, they can still do that.
Sure, that makes sense. Uh, One of the switching gears a little bit, of course, many of the cases and a lot of your uses within idiopathic scoliosis, but can you speak a little bit towards the use and the necessity of bands and the utility for bands in neuromuscular
Yeah,
or
I
syndromic
think
type cases?
I think syndromic and neuromuscular are the base case to start with, actually, because in all these cases, the bone is weak. So we all know our pedicle screws are not amazingly strong. We all know that you want to go quick, and you don't have the exact same goal of an idiopathic. So what I mean is that the correction rate is not always the key. So I think that if you want to introduce the bands to some surgeons, if they don't want to change what they're doing in idiopathic, you can still ask them to use them either in neuromuscular, saying that the pull-out resistance of your band will be greater than a screw, and that's something some biomechanical studies we've done, or use it in a dystrophic cases, because in dystrophic cases like Marfan, like Ehlers-Danlos, like neurofibromatosis, very often there are a couple levels where you don't have a pedicle. You don't have pedicle. You do a CT scan pre-op and you see that there are 6 levels without pedicles. And then if you cannot use the pedicles and you don't have any other implants, you don't just instrument them. But then using the band can add and increase your number of fixations. So actually maybe syndromic and neuromuscular are the base cases to start with when you want to get to that. And that's what happened in Philadelphia, for example. At CHOP, they're really old screw believers, but then the guy who's doing neuromuscular, he loved bands. He used bands. He used bands all the time.
Mhm.
And same thing I think in Toronto as well at Sick Kids, they've been starting to use sublaminar bands, but only in neuromuscular. But then they use a lot of them to distribute the correction, and they have great correction, and it's a smooth correction without loss of implant.
That makes sense. Are there any specific kind of contraindications in your mind for bands and in type of cases in which you try to stay away from bands?
Actually, no. I think that's the opposite. I think I have some contraindication for screws. So basically, I would say now what I do is I do CT scan and MRI in all my cases, and I preoperatively note on a piece of paper all the non-implantable pedicles, and I know that at these levels I will use the bands. The only maybe I would say I see the only location where you have to pay attention is that if you have a very lordotic spine, specifically between a T10 and L2, so the thoracolumbar junction, you'd always have to evaluate pre-op if there is a little bit of fat between your spinal cord and your lamina. Because it's true that at this junction, you have to be very careful in the depth of insertion. And sometimes when you open the yellow ligament, you see fat, and that's the most frequent case, and you're fine. That means that you have a couple of millimeters, that you have plenty of space to implant it. And sometimes when you open the yellow ligaments, you see the dura right away. So that means there is no fat. It's the amount of space is very limited. But I have to say that even in those cases, I never had any significant neuromonitoring alert, which means that the dura can really accept a little bit of shear movement applied on it with the band, which is very soft.
That makes sense. Do you see uh, any utility for jazz bands or some other type of jazz fixation for use in early onset cases where you're not necessarily doing the definitive fusion?
Yeah, I think that's a key point. I think, but this is more, I would say, a higher complexity ID.
Mm-hmm.
But I mean, the treatment you usually propose to early onset scoliosis is either traditional growing rods that you have to open every 6 months or 4 months to make a strength and make them lengthen, either magic rods. And in those cases, I'm not sure that there's a great advantage. But for all of the surgeons who are using Lukey trolley, and they want to keep a translation and basically an automatic growing ability of the spine, then the sublaminar band is very important and interesting because you can instrument the apex, connect it with the rod, but then you can still get that translation. So it can guide the growth of the spine. So for all of those who are using Lukey trolley type of constructs, that's interesting.
That makes sense. That pretty much I'm just looking through the questions here. I think that pretty much hits all of the questions that we've had from the group. So unless you have any other further comments, Professor Ilharreborde, I wanted to thank you for your time this evening. I know it's late there in France, and thank you for the education that you provided all of us.
No, you're welcome. I mean, I hope it will be helpful, and I think don't hesitate as well. I think if you have new surgeons who want to use the band, I think it's pretty interesting that they can send us a case. We can say where we would put the bands, and if they have some specific issues, I think that's interesting to discuss. That we can discuss that prior to their surgery, and if they're ever coming close to France, that's really the best way. I mean, I have to say the convincing rate of all the visitors we had in Ilharreborde is very high. And it's much easier to see the technique in the hands of someone who's really used to that than the description or any maneuver you could do on Sobone. So if you have people who are interested, they can come whenever to our hospital. It's pretty easy in France to scrub and to come to the OR. It's not that like in the US where you have to sign 25 papers. And so that can be convincing and helpful. And recently I had two guys who came from Australia. They had never placed them, and they were in relation with a rep, and they told me that they had the band since 10 years. They spent one day with us, and they found a lot of new ideas to use them, and they told me that for 10 years that they hadn't understood what was the real goal of it. So, and they were completely convinced, and now they're huge users in Australia. So I think it can really help convincing people.
Mm-hmm. Well, I can speak to that firsthand. I've been there myself and seen that dynamic directly. So appreciate your support and thank you for your time this evening.
Oh, you're welcome.
Thank you. Thanks everybody for joining us, and look forward to the next webinar in the series coming next month. Follow-up will follow. Thank you.
Bye-bye.